Here we will discuss Chapter 5, Adult Health and Nutritional Assessment. When we look at the role of the nurse, all members of the healthcare team collaborate and use their unique skills and knowledge to contribute to the resolution of patient problems by first obtaining some level of history and assessment. Of course, we get a health history and our physical examination, and then that develops our focus for each healthcare member. Note that we do document it in our electronic medical records. If they do not have an electronic medical record, they are still on paper. We want to make sure we know the rules and regulations on how that charting is done. You also want to note that your nursing process will guide the care for that particular patient through their stay in the healthcare facility. Considerations for effective communication, of course, like anything, you want to establish that rapport and respect. Making eye contact, you want to be careful on that. That can be a cultural issue, and this is where being culturally diverse plays a major role. Some cultures think it is disrespectful to make eye contact, so just be mindful if they're not making eye contact with you that they're not necessarily being rude, that it may be a cultural thing for them. Also, listening. If the patient has an issue and they're explaining it to you, don't be so hastily involved to disrupt them or talk over them. Go ahead and listen. Silence is a virtue, just like patience. You want to be aware of their nonverbal communication. Some patients or clients may be telling you one thing and their body language is giving you another sign. And this can be seen sometimes with child abuse or even elderly abuse and neglect. Also, the language proficiency. If they have broken English, they may not speak well. If an interpreter is needed or a translation device is needed, you want to make sure you get the proper tools for that so that you can communicate with your patient well. Also, avoid those technical terms and medical jargon. They do not understand it unless they are in the medical field themselves. If you know that, then that is fine. If not, then you need to break it down into their terms. And at the end, just make sure you summarize whatever you've gone over to make sure they understand it and ask if they have any questions. When we look at the ethical considerations, explain what the health history and the physical exams are, how the information will be obtained and how it will be used. Make sure they're in a private setting. Make sure they feel secure and okay with you doing the exam. Remember the right to refuse. If they refuse it, then you cannot force them to do so. Make sure you're not violating any HIPAA or confidentiality. And make sure you're documenting components of the health history. Of course, you're going to obtain that biographical data, their chief complaint, present illness, past history, family history. You want to go through your head-to-toe assessment and your patient profile. When we look at your patient profile, of course, this obtains all of the information such as sexuality, risk for abuse, stress, lifestyle, past life events, education, occupation, and things of that nature. Your physical assessment goes from head to toe. It's usually performed after you obtain the health history. Make sure you're in a well-lit area so you can visualize the patient. Of course, wash your hands. Put on gloves if you need to. Make the patient comfortable. Do not uncover the patient fully. Make sure they are comfortable even if they are with a family member. You want to ask them if it is okay for the family member to stay. Usually for your smaller kids, the parents or caregivers will stay. For your older adults, the husband, wives, significant others, they don't usually have to stay, but you can ask the patient if they want them to stay or step out of the room. Components of your physical exam, of course, your general observations, body movements, vital signs. You focus on the body systems. You don't have to do a full head to toe every single time if they're coming in, especially if you're in an area like the ER. You do a focused assessment, which is, what is your chief complaint? Let me see what's going on. If it is your ear, let me examine your ear. You're not going to do, let me, examine your genitalia, make sure, you have all your parts if they're coming in for an earache. So just use common sense and nursing judgment when it comes to your assessments. Of course, for your pediatric population, which we'll go over in depth in pediatrics, your assessments are going to be from head to toe each and every time. Your focus assessments, like I talked about, these will be seen mainly in your ER, or your doctor's offices if they're coming in for one particular thing. Assessment techniques, of course, your inspection, palpation, percussion, and auscultation. You should remember these from health fundamentals when you did health assessment. And here's an illustration of light and deep palpation. Auscultation of the heart. And here's a question involving physical assessment of a patient and their environment. And here's the answer and rationale. And when we look at a nutritional assessment, we want to provide information about obesity, undernutrition, and malnutrition. The main focus now within the U.S. is prevention of obesity, especially in our at-risk populations. So that will be your main focus, and healthy eating, diet, and exercise. Of course, your deficiencies that are caused or your disorders that are caused by nutritional deficiencies, you want to look at those as well. Lifespan considerations, like I said, your at-risk populations, your adolescents. One of the major things you want to look at is your females, their iron, folate, and calcium, and this is because of their menstruation. This is when they lose a lot of those nutrients, and of course healthy eating, they're not necessarily healthily eating. And then your older adults, and I do want you to refer to chart 5 and that is in your text as well on page 69, which goes over the nutritional assessment of an older adult. When we look at the components of a nutritional assessment, you usually will get your BMI, your waist circumference, and your biochemical measurement. This is not typically done at each physical assessment or doctor's visit, so this may be done as a health screen tool. So you want to note when these are necessary and when they are not. Your body mass index, of course, noting that BMI less than 18.5 is, increased risk for problems with poor nutrition, whereas your BMI of 30 or more is considered obese. And then they have a BMI greater than, I believe it is 40, that would make you morbidly obese. So I do want you to know the differences in those, and of course take ethnicity into account. And here's an illustration of a BMI chart, and that is also found in your text on page 70. When looking at the waist circumference, of course, if you have excess abdominal fat, your males will have a greater than 40, If they have greater than 40, this is excess. And for your females, it would be anything greater than 35. High waist circumferences, of course, puts these patients or clients at risk for these disorders such as diabetes, hyperlipidemia or dyslipidemia, hypertension, heart attacks, and even strokes. When we look at the biochemical assessment, these are some of your routine labs and electrolytes that we will look at. Your serum albumin, your electrolytes, your hemoglobin, of course, vitamin A and C, your lymphocyte counts, and they may even do a urine test. As far as the clinical exam goes, indicators of your nutritional status, the general appearance, you may be able to tell, a person that's anorexic versus just a person that is nutritionally deficit due to lack of resources. So there are signs and symptoms for these patients, like your patients that are bulimic and they throw up. They may have on their knuckles or burn marks in their throat and things of that nature, whereas the patient that is malnutrition due to lack of resources may have alopecia or things like that. Hair, skin, and nails, you can look at those. Jaundice, you want to look at the skin color, your mucous membranes, if they're dry, they're dehydrated. Of course, the abdomen may be sunken, musculoskeletal if they're weak, things of that nature. You will, and again, this comes with time, so you won't be able to necessarily look at a person and say, oh, you're malnourished. They may have a nutritional deficit, but something else may be going on as well. Look at the dietary data. You want to make sure you get a 24-hour recall, what they have for breakfast, lunch, and dinner the day before. If they're having problems eating or keeping food down, you may tell them to keep a food record, see what they're eating. You want to also consider religious and cultural considerations, because that may affect their diets and nutritional status as well. Evaluation of that data, of course, you compare it with the dietary guidelines, and that is found in your text on page, in figure 5-6, and that is in your text, I believe. Not really sure what page it's on, I don't see it. Oh, it is in your text on page 72. I apologize. It is right in front of my face. And that's the choosemyplate.gov. They do have nifty things on the website, so you can check out that website, and that would be a good website to refer your patients to as well when it comes to nutrition and diet. Also, you want to look at their fat intake and cholesterol levels. Looking at the factors that influence nutrition, of course, nitrogen balance, any hospitalizations, they may not like the food, it may be a cultural thing, so you want to kind of weigh the options there. Physical problems or limitations, they may not be able to feed themselves, they may have some kind of unsteady gait or something that affects them from holding their utensils or things like that, limited fixed incomes, and of course medications. Some of the medications that these patients take do limit their abilities to eat, so you do want to take note on that as well. And here's a question about a patient BMI of 32. And here's the answer and the rationale. And that will conclude chapter 5, and we will finish up with chapter 6. And here in chapter 6, we'll briefly go over the individual, family, and homeostasis, stress, and adaptation. This too should serve as a review from fundamentals. And if you can remember the steady state going from your external environment, or shall I say from the cell all the way to your external environment, which is your family, groups, community, and the society as a whole. And that illustration is also found in your text on page 78. When we look at the constancy and homeostasis, you want to review those, and those should be fundamental concepts that you remember, especially your homeostasis and what it actually means, your constant steady state. And then when we look at stressors, you want to go ahead and recall stress and coping and adaptation. There's different types of stress. You have physical, psychosocial, physiologic, which is your pain, heat, chemical, fear, things like that. So you want to recall those and understand the differences. When we look at your psychological response to stress, coping with stressful events, and this can also be a cultural thing. People cope with stress in different ways. So when you're assessing your patients, you want to also assess more so than just the event that they're stressing on. You want to assess the patient as a whole. When we look at physiologic response to stress, we look at Sly's general adaptation syndrome, and that is found in your text on page 80. And you just want to briefly review that. And what I really want you to look at is that fight or flight response, and of course your sympathetic nervous system and how that jumps into gear when we're dealing with stress. And here it goes a little more into detail about Sly's general adaptation syndrome and the 3 phases. And then it goes more into how our brain copes with stress and how stress affects our overall brain, our hypothalamus, our limbic system, our hypothalamic pituitary system. Different things are activated within our bodies when stress is apparent. Looking here at the physiological responses to stress illustration, and this is also found in your text on page 81. Here's a question in regards to a patient that's been in an accident and that initial sympathetic nervous system response. And here's the answer with the rationale. And although everybody copes with stress differently, there can be a maladaptive response to stress. So we do want to look at that. And this is inappropriate coping. We don't want the patient to, as I like to say, spaz out and cope inappropriately. So we have to intervene sometimes when chronic stressful events keep occurring. When we look at cellular adaptation, of course, you have hypertrophy, atrophy, hyperplasia, dysplasia, and metaplasia. You want to review those terms and what they mean if you have forgotten. And the causes of cellular injury, with the most common being hypoxia, chemical agents, and infectious agents. You do have others that cause cellular injury, such as your nutritional imbalances, immune mechanisms, and genetic defects. And here is a question on cellular adaptation known as dysplasia. And the answer with the rationale. And we look at nursing management, what we do as nurses to help our patients cope with stress. Of course, the main key is prevention, but if we can't prevent it, early identification is the first thing. Of course, assessing, and depending on the culture, they may display it differently. So they may display it through increase of vital signs, emotional distress, problems in the movement or sensation, impairments or lesions, and even some diagnostic studies. When we look at nursing diagnosis, here are a few that can be related to stress and those stressful events we encounter on a daily basis. And some nursing interventions that we can employ. And here's a question about nurses and teaching the patient on guided imagery, and this is a coping mechanism for stress for some. And here is the answer and rationale. And this will conclude chapter 6. And with the conclusion of this lecture, we have covered chapters 1 through 6, which will be exam number 1.